Morning. Um, Thank you for joining our PCORI sponsored webinar series that's focused on metastatic cancer patient outcomes. And today's focus is on, palliative care. This webinar series is a direct result of input from patients, caregivers, clinicians, researchers, and all stakeholders invested in metastatic cancer research. Our objectives today are to describe the evolution of early palliative care for patients with metastatic cancer, explain the impact of unpleasant symptoms on quality of life, discuss the benefit of early intervention to mitigate or ameliorate symptoms for improved quality of life, and provide strategies for empowering patients and families to advocate for early palliative care. We have three wonderful presenters today, and I'm going to introduce them in just a minute. So we are going to have them each talk for about 10 to 12 minutes, and then we will open up for questions and discussion. So as you can see on this slide, there's the chat box that you can open. There's also a Q&A box. Any questions that you have or comments that you have for discussion later, please post in the chat or the Q&A. My colleague, Dr. Dan Welch, is going to be looking at the chat and the Q&A box for the questions as they come in, and then we'll make sure we have time at the end of the presentations to go over those questions. Today's panel presenters are Dr. Marie Bakaitis, who is a professor at the Marie L. O'Coran Endowed Chair in the School of Nursing and co-director, Center for Palliative Care and Supportive Care, and the Southeast Institute for Innovation in Palliative and Supportive Care at the University of Alabama at Birmingham. She has participated in or led over 50 clinical trials in early palliative care and symptom management. She has developed innovative methods such as telehealth and teleconsultation to reduce health disparities for Deep South rural and minority cancer patients and family caregivers through an implementation trial. She is also collaborating with colleagues in Turkey, Honduras, and Singapore to adapt this early telehealth palliative care for these cultures. Dr. Bakaitis received her Doctor of Nursing Science degree and postdoctoral fellowship from Yale University. Dr. Elizabeth Wolfe Birchfield is an assistant professor of medical oncology and palliative medicine at the University of Kansas Health System. She completed her internship and residency in internal medicine and her fellowships in medical oncology and hospice and palliative medicine at Vanderbilt University in Nashville. Following completion of her training, she joined the faculty at the University of Kansas, where her areas of specialization are in genitourinary medical oncology and outpatient palliative medicine. Her areas of research interest are in supportive care, quality of life, and patient-reported outcomes in genitourinary malignancies, as well as the integration of palliative care into routine cancer care. Ms. Jenny Mason is the Executive Director of the Inflammatory Breast Cancer Research Foundation, a grassroots lay advocacy organization dedicated to improving the lives of those touched by inflammatory breast cancer through the power of action and advocacy. Following a diagnosis of inflammatory breast cancer in 1994, Jenny became involved in breast cancer advocacy at a local level while working full-time as a mental health nurse. She now represents Indiana University on the Translational Breast Cancer Research Consortium and is one of two advocates on the Breast Cancer Committee for the SWOG Clinical Trial Group. Jenny received her BS in nursing from Eastern Mennonite University in Harrisonburg, Virginia. Without further ado, please welcome Dr. Bakaitis.
Can you guys hear me?
Yes, we can.
Okay, sorry. Now I'm unmuted. Hello, everybody. It's so nice to be here with my co-presenters talking about palliative care in metastatic disease, which is certainly one of my passions and my area of research focus. My goal for this particular opening is to introduce a little bit about the evolution and benefits of early palliative care for patients with metastatic cancer. And I'd like to begin with a case. My focus and practice and research is really focused in rural underserved areas. And so the case that I chose to illustrate the importance of early palliative care is Mabel, who's a 78-year-old African-American woman with recurrent breast cancer. She has lymphangitic pulmonary metastases and dyspnea. She's admitted to a local critical access hospital, which is not uncommon for people who are in rural areas. Some social history is Mabel is a Baptist. She has 5 children, 10 grandchildren, and 3 great-grandchildren, and all of them live up north except for one. She and her family think that she will get better cancer treatment at the academic center 90 miles away. And when she arrives there, her oncologist recommends palliative chemo. Mabel, being of her particular generation, defers to her physician's advice. Unfortunately, the family can't visit because of transportation issues, another very common situation in rural areas. Unfortunately, Mabel starts to get problems from her chemotherapy, and she is short of breath, intubated, and transferred to the ICU, where she dies alone following a lengthy resuscitation effort, while her physicians are attempting to contact family to understand her wishes for life-sustaining treatments. We'll get back to Mabel and see how things might have gone if she had had exposure to early palliative care. But what's clear for sure is that, like her, many patients will transition through a variety of healthcare settings. They may go to a tertiary center. They may spend the majority of their time at home. And as you can see, the other transitions that Mabel experienced. The problem, and hospice care as one type of palliative care is always in question for patients with cancer as well as for people in rural areas. The problem is, where is palliative care? And for the most part, we know from our statistics that tertiary centers are most commonly where palliative care is located, yet Mabel spends very little of her time at those centers. It's good for us to remember back in the beginning, the World Health Organization recommended early outpatient palliative care, and this is actually an illustration from their original technical report that was, believe it or not, back in 1990. And what they said was the dichotomous model, which is shown on the left, is what was currently happening, and their recommendation was for the continuum of care model, which is shown on the right. And what this states is that pain and palliative care relief should begin at the time of diagnosis, and that it should increase as the patient's disease progresses and as curative treatments diminish. However, even though this was, and the World Health Organization proclaims palliative care as a human right, even so, most consumers are not familiar with palliative care, and even many providers are not well-versed in all aspects of palliative care. And what's shown on this slide, this pie chart, is just the data to support that notion that in a opinion survey that was done of over 800 adults, 70% had absolutely no knowledge about what palliative care was. And very few were somewhat knowledgeable or at all knowledgeable. So this could be pretty discouraging to people who do palliative care practice, research, or education, but I like to think of it in a positive light. At least patients or the general public don't have misconceptions if they're not at all knowledgeable. So it gives us a little better starting point. What would I tell someone about what palliative care is? Well, the same group, the Center to Advance Palliative Care, that did that consumer survey that I showed on the prior slide, worked with consumer groups to say, when they described what palliative care was, what is the definition that would be acceptable to you? And so on this slide, you see what the result of that definition is. And I highlighted a few terms in red to really make the point that palliative care is appropriate for any age or diagnosis, for patients with at any age or any diagnosis, and their families. And family members are a key member of the palliative care team for the patient. That it provides relief of symptoms, pain, and the stress of a serious illness. And that word stress was chosen very carefully because things that we think nothing of saying about emotional support or psychological or social help, that can often be a stigma for patients. And so substituting the word stress was a much more acceptable term for patients to embrace the type of care that they would receive. Provided by a team, and if there's nothing else that the trainees that I teach remember, I stress that palliative care is an extra layer of support. It's the easiest and most simplistic way to explain it to patients, and that it can be provided along with curative treatment. And so I think these are really the key elements that are important to communicate. On this slide, I show what we consider the DNA of palliative care. You know, what's in the syringe? What is it that palliative care provides? And you see the 4 essential elements of symptoms and function, psychosocial and spiritual care, social and support and family care, and communication and decision support. And this type of care can be provided by generalist and interdisciplinary specialist teams. So they are really the sort of backbone or the structure on which this type of care is provided. Lastly, just to sort of put into context, what the overall definition is shown here, where palliative care is really equivalent to supportive care in many of the definitions, and that there's often a mistaken belief that palliative care and hospice care are the same. But actually, palliative care is really the umbrella term, and hospice care is what is provided usually within the context of the Medicare hospice or other insurance benefits. And it is at a more towards the end of life stage, whereas comfort care is what people often think about, even hospice care, as that care that's provided in the last days or hours of life. Symptom management, on the other hand, is part of what we do in palliative care, but it's not the whole picture. And there are parts of symptom management that don't have anything to do with palliative care. So at the end of the day, where are we with palliative care and metastatic cancer? Well, a significant number of studies were done, and many organizations, including the National Comprehensive Cancer Network, excuse me, the Institute of Medicine, ASCO, or the American Society of Clinical Oncology, and and there's been a number of meta-analyses, but I just show one here, have said we should provide what's at the top of the screen there and not this, which is the old model of palliative care that was shown in the first World Health Organization slide. In fact, the meta-analysis concluded after reviewing 43 studies that palliative care interventions provided early were associated with improved quality of life and symptom burden. And ASCO came out with a strong statement to say that inpatients and outpatients with advanced cancer should receive dedicated palliative care services early in the course of the disease, concurrent with active treatment, just like what was recommended years ago by the World Health Organization. Further, they suggest that providers refer family and friend caregivers of patients with early or advanced cancer to palliative services. So let's go back and see what would happen to Mabel in this theoretical world if everyone received, our motto is palliative care everywhere for everyone, and if she had received this type of care. And so you remember the case that's just reminded here. However, the new scenario is that she and a local child, her local son, are referred to early palliative care by a lay navigator. And they work with their telephonic palliative care nurse coach to identify Mabel's goals and values if her disease progresses, including local health care, hospice, and home care resources. One of the things, as I focus on providing early palliative care, is that there are many novel ways, such as lay navigation and telehealth, in which palliative care can be provided, particularly in improving access in rural areas. So given that she had received those early palliative care resources, she has learned now how to have conversations with her family about her wishes. She completes an advance directive, which identifies her oldest son as their caregiver and her durable power of attorney for healthcare. She discusses her advance directive with her physician and family members and is sure to place it in her medical record and provide copies to all concerned. This time, as her disease progresses, she's seen by her local palliative care clinician in her home community, and a symptom management plan is developed. She continues to attend her regular church activities, which were very important to her, and her congregation prays for her and provides support by providing meals and helping with chores. So now she no longer feels as though she's going to get better care if she goes to the academic center. Her local and distant family have regular Skype calls with her local physician to answer questions and get on the same page, and they make a regular schedule to visit and reminisce or do standard of care, life review, and legacy work that is common with an early palliative care approach. So these other issues about the family visiting and having the palliative chemo 90 miles away are no longer issues in her care. So finally, at this point, you're now caring for Mabel at home when she gets short of breath. And what her family and she decide is that the extra support from home hospice may be a good idea. Libby is going to talk a little bit more about expanding on the symptom management care, so I'm going to leave that to her. So Mabel now lives comfortably at home for months. When death seems closer, her family and church members gather to say their goodbyes. And this ICU scenario that has been all too common is eliminated from her life story. So now, as her hospice clinician, you feel a sense of satisfaction knowing that you had an active part in ensuring that Mabel's wishes were known and followed. You make a bereavement call, and her family continues to thank you for your care, and that because they know their mother is at peace. And they tell all of their friends and congregation about the benefits of palliative care and hospice for their ill family members. So this advocacy that can develop once people have experienced the benefits of early palliative care is something that Ginny is going to close our webinar through. So I'm going to turn it over to Libby.
Hello, everyone. Let me pull up my talk. Let's see. Is this, looks like we should be sharing. Okay, let me see.
Looks good to me.
Yeah. Looks great.
Great.
Thank you.
Well, thank you so much to the organizers for involving me in such an important topic for this project and for this group. I myself am a practicing medical oncologist and palliative care physician at the University of Kansas Cancer Center, which I do think gives me a unique viewpoint into the role of palliative care and some of the ways that it can mesh And I want to talk some about the ways that palliative medicine, particularly early in cancer care, can impact symptoms, and then revisit Mabel's story and talk about what that could look like and break down a little bit more concretely what symptom management could look like. There we go. Well, certainly, I would imagine that everyone who's participating in this webinar is aware that advanced cancer is common and that symptoms are unfortunately a reality for most people who are dealing with advanced cancer or any cancer diagnosis. There is certainly data that suggests that unpleasant or distressing symptoms are one of the main reasons that many cancers are diagnosed to begin with, and that there is a risk of additional symptoms from the treatment itself. So, as you might imagine, there is data to support the symptom prevalence and impact of patients dealing with advanced cancer, and the fact that not only are they common in that most people are experiencing, essentially all patients are experiencing at least one unpleasant symptom, but that almost 2/3 of patients have more than one unpleasant symptom, and almost 1/3 have more than 5. That is staggering. And certainly it's just only, that quantitative way is one way to paint a picture about the experience for patients. We do find that younger patients sometimes report more distress from their symptoms, but that there doesn't seem to be a change in the prevalence, and there don't seem to be any differences between men and women in reporting of unpleasant symptoms and cancer. So anyone who's experienced pain for even a moment in their life would be aware that adverse symptoms also diminish the quality of life that patients experience, and there's clear data that pain and other symptoms diminish functional status and capacity and threaten the ability for a given patient to live independently, and that it leads to poor quality of life and caregiver burden and distress. Not only are worse symptoms associated with more impacts on functionality and quality of life, but just having a more number of symptoms is as well. And not only that, but fear of pain and symptoms is a huge source of distress, and that alone can impair functionality. So as Dr. Pakaitis alluded to, palliative care has historically been reserved for end of life, but there has been a wealth of really wonderful data demonstrating some benefits to early palliative care and the ways that it can impact symptoms and quality of life. So to break that down just a little bit so that we can cover it in the time allotted, there are a number of studies that have demonstrated lower symptom intensity with early palliative care. And this data covers a wide breadth of symptoms because of the assessment tools that are used. Some of these tools, one of which is called the Edmonton Symptom Assessment Scale, or ESAS, looks at things like systemic symptoms such as fatigue, weakness, anorexia, sleep disturbances, as well as local symptoms such as more nausea, decreased appetite, and pain in a given location. Mood has also shown improvements with the integration of palliative care early into the cancer care. And not only that, but caregiver mood has also been positively impacted. In addition to improved symptom control, quality of life is improved accordingly. And this has been shown for patients with advanced cancers in a number of types, as well as patients who are receiving a stem cell transplant, and even during the hospital course of their transplant itself. These impacts can be transmitted by in-person visits, which is a majority of these studies have included in-person visits with specialty palliative care physicians or nurses, but also telehealth, as in some of Dr. Pakaitis' work, has an impact on and is a really effective way to deliver palliative care and can really reach patients who otherwise would have a difficult time reaching a specialty palliative care provider in person. I just want to briefly touch on this, but palliative care certainly has been shown not to shorten the length of time that patients with advanced cancer live. And in fact, there have been a few studies that show a trend towards, show either a statistically significant increase in overall survival at a year, or a trend towards that. And while it is difficult to break down what the special sauce of palliative care is that ultimately conveys this benefit, what we do know is that patients with advanced cancer receiving early palliative care also have less aggressive care at the end of life, which often means less chemotherapy near to the time when they pass away, and have fewer ICU stays and longer time in hospice. So clearly these interventions do not shorten a person's life expectancy. So I wanted to revisit Mabel's story a little bit and talk about the way that palliative care could impact her symptom control in a more concrete way, and then could ultimately lead to some of these better outcomes at the end of her life. So palliative care, when integrated early into cancer care, those visits and meetings and teleconferences can take a number of forms. And I think one of the strengths of the field of palliative care and in palliative care training in general is meeting people where they are. But some of this inevitably will involve symptom control concerns and plans, as well as prescribing. So some of what we try to do with early palliative care intervention is to create a stepwise plan that could map out an action plan for a given symptom, sort of the way that an allergy action plan might, but that can look forward. We can have plans in place so that patients aren't forced to call an ambulance, go to the hospital if that's not what they want to do, and use hospice services when it is appropriate for their care. So if we're looking at the sort of historic standard of care plan, which thankfully, due to ASCO guidelines that recommend early integration for palliative care for patients with advanced cancer, is becoming less and less the standard, but we'll call it our historical standard. So typically the way that would go if a patient isn't already meeting with palliative care would be that our patient Mabel would have shortness of breath. Then depending on the severity of it, it could look a number of ways. Typically, let's say that the patient has breathing treatments at home and she uses either inhalers or nebulizers. So she and her oncologist could map out a plan to, let's say, use a breathing treatment if she gets short of breath. However, if that does not resolve the symptom, then the next step is often unknown, because not all oncologists or hematologists, primary care doctors, geriatricians, et cetera, would be comfortable using opioids for acute shortness of breath or progressive shortness of breath. So that may or may not be an option. For severe shortness of breath, that is usually going to involve the patient going to the emergency department. Even when everyone has the best of intentions, sometimes that is ultimately the only way to manage a symptom crisis is through the emergency room or through a scheduled admission. From there, if the patient has improvement, then they may have if they have an improvement of their symptom, then they could schedule a routine visit with their oncologist in clinic. If they have some improvement with managing their symptom, then it could result in an urgent visit with an oncologist or a walk-in type visit. But if they have worsening shortness of breath, then that may result, again, not only in an ER visit, but hospitalization or possibly an intensive care visit. And while those services are wonderful and have many positive impacts on patients' health, when we're talking about patient with an advanced cancer, that may or may not be something that's desirable for the patient and family and could result in aggressive care that may not change the ultimate outcome. So if Mabel were to meet with a palliative care physician as part of early palliative care, while we would look at goals of care and help with communication with her family, loved ones, oncologists, and other members of the healthcare team, a lot of what we would look at in terms of symptoms would be trying to anticipate what symptoms she would be most likely to have based on her history and her location of disease or what she's currently experiencing, and then discuss what sort of steps, what ultimate endpoints are okay. Would a hospitalization offer her benefit? Perhaps, let's say Mabel has COPD and has had good responses to a short course of antibiotics and and nebulizer treatments and steroids, then perhaps that would make sense. But if the patient's shortness of breath is anticipated to be due to his or her advancing cancer, then a hospitalization may not ultimately feel helpful. The same thing, the other side of the coin is that early, even when we're looking down the line at a given symptom, a lot of palliative care physicians will try to arrange a hospice informational visit. That is a sort of low risk scenario when if done in conjunction with an oncology team who feels that's medically appropriate, then it can allow the patient to meet with hospice, understand what services can include, and then, as is in point number 3 here, make decisions about when to enact hospice. So if Mabel has shortness of breath during this scenario, if it's mild, again, the plan may be a breathing treatment. It may help her, and if it does, then we're done. She goes back to square one. If it does not resolve it, then at that point, often the response of a palliative care team would be to employ a short-acting opioid. Opioids have known benefit with the symptom of dyspnea, and then often would have another plan, sort of a plan C, if you will, that if breathing treatments and an opiate are not enough, then using moving air. There is a wealth of data in the palliative care literature demonstrating that moving air can help relieve dyspnea. From that point, if we enact all 3 of these strategies and she has great improvement, then she could update her palliative care about what happened. They might schedule a visit to, again, revisit her symptom control and plan, and then talk about the role of hospitalizations in hospice. If she has some improvement, then depending on what her goals and what outcomes feel okay, hospitalization could be considered if she has only some improvement of severe dyspnea, or at that point, if she has only partial improvement, engaging hospice could be a very appropriate next move. And finally, if she has worsening or no improvements in dyspnea, then urgent hospice admission could even be considered and could be one mechanism to keep her at home, in her home surroundings. But in this instance, she would be familiar with the team, she would be engaged with the agency and have an order already, and therefore it would remove so many barriers for her. And while this isn't what everyone's symptom plan looks like, without having palliative care involved, it's often difficult to have this sort of symptom symptom plan. As an oncologist myself, I will tell you that I work closely with my colleagues in palliative care whenever I can, because there are often so many moving parts to anyone's cancer treatment plan that it's difficult to have this sort of foresight when looking at labs, scans, and other factors. So I would conclude by saying that palliative care is a complementary discipline to medical oncology, hematology, and a lot of other disciplines, and can improve symptoms and quality of life for patients with advanced cancer, and some symptoms improved by caregivers. It does not result in shorter life expectancy, and that palliative care physicians and teams can help to provide the foresight that comes with experience with advancing illness to prevent patients from having outcomes that they do not wish to have. Thank you all so much. Jenny will take over and talk some about the patient perspective, which is something that is essential to all of this and can help put things in even greater context.
Great. Thank you, Libby. And I think, Jenny, we're turning it over to you now.
Okay, thank you very much. And thank you for this opportunity to provide a pretty generalized patient advocate view. I've been working in patient advocacy for about 20 years now and have seen a variety of experiences with patients. And while I have advanced cancer, I'm just a little step away from metastatic disease, as I have had inflammatory breast cancer. So I'm going to give a lot of things you've already heard about from a maybe a little bit different perspective, and also some case examples. Okay, next. Thanks. You've already heard from the other presenters the pros and cons of palliative care. Not very many cons, fortunately. I've tended to use the term supportive care because people want to link palliative care with hospice, and that makes people uncomfortable. We've heard about the relief from pain and other symptoms or side effects. And I think one of the real important things is to get the support to live as actively as possible throughout your disease and support for your family. Access to that care can be a challenge, and we want to give people the best quality of life possible. And a really important piece is that a patient have a treatment plan designed around their goals. And I think palliative care plays a huge role there. And unfortunately, sometimes your goals as a patient may not be the same goals as your goal is trying to cure you. It's important for patients to speak up about what their goals are in their treatment of even their advanced disease. Next. So I'm going to talk to you about 3 different scenarios. These are not individual patients, but things that I've worked with in patients over the years, and what we have seen and what could improve those, just as you've heard about Mabel and her situation. The first is about a patient on a clinical trial. This is a patient who had a long period before metastatic diagnosis, and once the metastatic diagnosis entered the picture, had a relatively indolent disease. She was able to continue to work, and her treatment was pretty successful. But then some progression after going through multiple lines of therapy, the clinical trial looked like the best choice. Seeing 3 different physicians because she couldn't get the kind of care locally that she needed with the clinical trial. She had a local oncologist, one at an academic medical center, and then a specialist as well. Clinical trial had its ups and downs. And she and her family had talked long and hard about what her goals for treatment were. She had a young child and wanted to be around as long as possible with him. Sadly, with 3 different providers involved in this scenario, while she and her family talked about what she wanted, not all 3 providers were on the same page with her. A crisis on a weekend resulted in not the planned, family-oriented, peaceful kind of death she had hoped, and everyone ended up really disappointed afterward because there wasn't that communication between those providers to know what she really wanted and what was important to her. And I think that's one of the challenges for patients often is if you have multiple providers involved in your care, making sure they all are on the same page with what your goals are. Scenario 2, a patient who either didn't hear that her treatment might involve rash as a side effect, or just wanted to, like we often do, minimize a symptom. She was on a new medication. Again, when you're in a metastatic situation, you may not have many options left. She was hesitant to mention anything to the physician about it. There was no physical exam in her repeat visits to the doctor. And when she finally did get so uncomfortable that her spouse brought it up to the doctor, turns out that this was actually a skin metastasis and really needed to be biopsied and treated more aggressively. And I think that's another challenge is when we're in metastatic situations and our lines of treatment are running out, there can be a hesitancy to report symptoms, even though the physician may be more than willing to help manage those problems. But a patient may not want to bring that to the forefront for fear of just another option being out of the way. And they're further along that line with maybe reaching the point of no more treatment options. My third scenario has to do with something somewhat similar to scenario 1, but a patient who was just very adamant about planning as she moves through her treatment, what she wanted to do when the time came for her to choose no more treatment. And she made it very clear with her family what her choices were. While not all were thrilled with the idea that at some point she would choose to stop treatment, she was very proactive in getting a good palliative care management. She was seeing a pain specialist. She was coordinating her care. This is a very organized person. I admired her abilities to do those kinds of things in the midst of dealing with metastatic disease. The challenge came when she thought all of her ducks were in a row, and her doctor ended up on an extended vacation. I hesitate to use the word vacation. I believe it was a medical leave due to a family problem. The doctors who were taking over didn't necessarily know some of her wishes, and she ended up in a situation that was not her planning and was just very distraught. And you have to wonder if some of that stress and frustration didn't hasten her death at the end simply because she was so concerned about things not moving the direction she wanted. So you've heard from the other presenters about the importance of early palliative care, whether it be metastatic disease or initial treatment. I think it is essential that patients speak up early and they make sure that they understand what the experience may be with the medications they're on, that their family's involved, that everyone is on that same page. And these are uncomfortable topics sometimes for families to discuss. And we have to give them permission. It's also important sometimes for a patient to have the opportunity to speak with their provider without their family present, because I know many times patients opt to stay on treatment longer than they might want to because they feel like their family needs them to do that and they don't want to let them down. So I think on both ends, we need to be responsible for making sure the patient has that opportunity to express their wishes. And as a patient advocate, I think we also have an opportunity working with other patients to encourage them to seek out these things, look for ways to get those needs met, and to see palliative care as a positive and not next step into hospice. And there are times that people talk about changing the language, and I think perhaps that's necessary, but it's webinars like this and other ways of getting things out into the public that help us to make a difference. Thank you for giving me the opportunity to share.
Thanks to all three of our panelists today. I'll start out with one of the questions that's come in online. It asks, how do you navigate collaboratively with a medical oncologist regarding the patient care? Sometimes patients feel uncertain who they should contact with their specific concerns and symptom management. I'll leave it open to whoever would like to answer that question. Please unmute yourselves if you're.
Well, this is Libby Wolf-Birchfield. So I think that this is a very astute question because this is something that does come up as someone who practices in both disciplines. This can be tricky, and I think the way that we can be, the ideal scenario is that question would be asked to the palliative care provider and or oncologist. That doesn't always happen, but I would say from the standpoint of my palliative care practice, generally it is never the wrong answer to ask your palliative care provider whether they can help manage a symptom better. That's almost never the wrong answer. If he or she decides that that is something that needs further workup and that the oncologist needs to know, then certainly they will direct you in that way. But the palliative care philosophy, when it comes to education of all sorts, whether with our peers, with more formal learners, or with patients and caregivers, is usually that you can always ask, and we can teach on the back end. Even if we're not the right people, we'll help you find them. But I would say that often the way that we try to work collaboratively looks like the palliative, if symptom management is a big part of the palliative care role, then we do try to keep that within our own discipline. And if anything, just to offload the medical oncologist or hematologist so that they can focus in on other concerns that the patient is dealing with. But as I said, I think it looks different for every person. Typically, there will be practice patterns in place between a palliative care physician and the oncology practice. But as much foresight as you can have, the better, but it's never wrong to ask palliative care. Well, I'll steer you to someone else if that's what's needed.
And I completely agree with what Libby is saying, and would go another step further to say that these things, as you were indicating, should be negotiated up front. And so one of the benefits of early palliative care is that the that sort of negotiation is understood. So if there was a consultation up front that was done, then the palliative care provider will be sure to provide that note and have agreement about, well, if symptom X or Y or problem X or Y, comes up, how that's going to be managed. And in some practices, I know that palliative care will prescribe certain medications. I know in our practice, the use of methadone for pain management was something that the oncologist didn't feel comfortable with, and the palliative care providers were all, had special training in how to do that type of pain management. So it's really something like, as you said, Libby, that really needs to be described or to be identified up front, and not have the patient be wondering and figuring it out, at a crisis. I think our hospice colleagues do a great job of negotiating that with the oncologist or the palliative or the primary care provider. And sometimes in palliative care, we need to make sure we have that same kind of explicit planning that goes hand in hand right from the beginning.
Well, another question Ginny, would you like to add anything?
No, that's a good answer.
Another question that's just come in is for each of you, and I'll start with Ginny first. What do you think the biggest barrier is to developing a culture in hospitals or clinics that embraces palliative care?
That's a really tough one.
That's why I started with you.
Thanks a lot. I can at least say in 20 years as a patient, I've seen improvement, and that's encouraging. I think you're more likely to find that in a larger academic center than a community hospital, sadly. And that's where most patients do receive their care, is in a community hospital. And so we maybe need to really work harder at helping those institutions develop programs and understand this need. And perhaps some of that starting with just the very fact of having navigators for many cancer patients, because it is a terrifying thing to get a diagnosis of cancer. Even if it's an early stage cancer, we're programmed, when we hear that word, we think death. And as you get some more education about it and your disease, I think hopefully you can grasp it and kind of wrap your brain around the idea. But having someone there to help you know what you need. I mean, we're all novices when we're diagnosed. I'm a nurse, but I didn't know anything about dealing with a cancer diagnosis. And some of palliative care, I think, is helping you to find those supports and your resources so that you aren't trying to climb this mountain by yourself.
Terrific. That sort of leads into the kind of work that you've been doing with telemedicine and palliative care. Marie, would you like to add anything?
Yeah, I mean, usually what we talk about are sort of the three biggest barriers are patients themselves, providers, and systems, the healthcare systems. And so you really have to have a multi-level approach to change culture. We just completed a project in rural communities trying to implement early palliative care in 3 community centers, because our research has been done predominantly in an academic center, and so you can do it there, but as Ginny so eloquently said, the patients are not there, and as I've said in the slide. And so it really has to start with a local champion, because there are barriers that could be overcome, but if the administration and oncology or others, if you don't have somebody locally who really wants to champion this, you're kind of dead in the water. I hate to say it. So I think it's starting with a local champion, getting together stakeholder groups, and really in an incremental approach, trying to work on the biggest barriers that are unique to that setting. I mean, if you've seen one palliative care or community setting, you've seen one. That's just the way it is. And so it really has to be individualized work, partnerships between community and academic centers, and a champion locally to do it.
Did you want to add anything, Libby?
Well, there isn't much to add, because I think that both Ginny and Marie have such a wealth of expertise in this, and my perspective is different only in that, since I provide both types of care in a somewhat compartmentalized way, actually, in addition to the essential nature of needing a champion, and then and leading by example, I think what I find is that gathering those stakeholders is where the sort of boots on the ground approach helps, by having one positive palliative care interaction early in the care that spans the length of the time that the patient is treated for his or her cancer. It demonstrates that palliative care physicians aren't out to change, to de-escalate care. They're really there to facilitate care, and then that particular oncologist will be more likely to refer in the future, I believe. Mm-hmm. And therefore, the other thing is that because they're, Ginny and Marie are absolutely correct in that this special resource is often much more available at academic centers than in community sites. I do think that's another way that academic medical centers can lead by example, by having, if they are collaborating with a local oncologist and every time they send records, they send the palliative care visit and the oncology visit, that speaks volumes, and it just takes the scary away from that oncologist in this community setting, and it leads them to think, okay, well, if this is the person I'm referring my patient to make recommendations about the management of her treatment, or this patient's on a trial at this institution and is getting palliative care, well, then I guess it does work. And then it can sort of trickle down a little bit. That's my hope. I wouldn't say that there's data to back that up, but since I work in an academic institution, my hope is that will be one of the impacts that our practice can have over time.
Seeing heads shake positively, I think there's some agreement in that interpretation. 2 semi-related questions have come in. They're about resources and insurance and Medicare, and whether or not it's covered financially, but also I think one of the attendees asked, how do we get the people power to focus on quality of life, which is really the bottom line for palliative care. So how do we get the resources, and are there limitations in getting them for palliative care for patients?
So I'll start out if that's okay. So we at the University of Alabama at Birmingham, and there's 8 centers across the country that are considered palliative care leadership centers. And so we've worked one-on-one with organizations that want to do it. The funny thing is that people think, well, you can do something like a palliative care program without, sort of having the resources and expertise and program development. It's the same as developing any new program in any organization. No one would think about embarking on starting to do bone marrow transplant, for example, without having, some kind of, training and planning and business plan and those sorts of things. And so while there have been efforts that I've noticed of, there might be like a nurse who's trained, or, maybe one physician, a multidisciplinary approach is really what's ultimately needed. And we're not going to have that same kind of program, here in Selma, Alabama, as we do in Birmingham. And so partnering again with a program, if you don't have in your local setting all of the resources, partnering with someone who does and looking at some of these innovative ways to increase that access is really important. As far as I don't know if the question was really directed at like reimbursement, and I'm sure that, Libby can speak to this. Palliative care is reimbursed acutely, in acute care setting, in outpatient, as good or bad as anything is reimbursed. Like if you were going to get a specialty consult from an infectious disease or cardiologist, palliative care is reimbursed. We don't do a lot of procedures, and so the reimbursement is really based on time and, level of service. And it's rarely enough to sort of make up for the salaries of the providers, the billing providers. And so philanthropy has been a real important partner in many palliative care programs to make them financially stable. A lot of programs, there's so much data to show that when people get good palliative care early on, that costs are less. And so some savvy administrators will know that, and it's really not about decreasing costs, and you can't guarantee that's what's going to happen. But palliative care is generally very cost-effective care. They don't necessarily want to hear about cost avoidance, though, and so unfortunately, in our still fee-for-service, very focused society, those are important considerations in program development.
Any other questions or comments from the others?
This is Libby. Just very briefly, I'll mention that so Maria is certainly correct in that palliative care is a subspecialty of internal medicine, and so it is reimbursed like other specialty visits, whether it's with Medicare, Medicaid, or commercial insurance. And the only other thing I'll mention is that the Center to Advance Palliative Care, CAPC, does have some developed resources about starting a palliative care program. They're pretty comprehensive, and while certainly that will not, cannot, should not take the place of the intensive planning that you would need to start any clinical program, as you said, a transplant program or anything of the like, it can give some mental framework about what the planning should look like and how other successful programs have approached that process. So that is a resource available on the CAPC website, I believe.
Super. Well, it looks like we've neared the end of our hour for this webinar. I would like, on behalf of Jill, as co-organizers for this, like to thank all of our panelists for really stepping up to the plate and talking about a topic that is clearly important, but is not always discussed as openly as you've made it today. I'd like to ask all of you who've dialed in to please give us feedback. Have we covered the topics that you wanted to hear about? And give us suggestions for topics in the future, because that's the goal of these webinars as well as the whole PCORI system. So with that, Jill, did you want to add anything else?
I just to follow up, I am going to put together a very simple survey in SurveyMonkey just to get some feedback about any topics for future webinars or future discussions. So we do want to hear from you. And thank you again to our panelists. We are very appreciative of you sharing your expertise. And thank you to everyone who joined today.
Bye-bye.
Bye.
Bye, y'all. Thank you.
Thank you all so much.